Each episode, we're going to dive into evidence-based strategies, cutting-edge research, and real-world insights to help you elevate your practice and empower your clients. Okay, so welcome to the Rehab Blueprint Podcast. Okay, welcome to the Rehab Blueprint Podcast. Today is an extra special episode because we managed to get rid of Giles. So that's a benefit, that's a plus. But today we are very lucky to have Jordan from the Perth Injury and Pain Clinic. Welcome to the podcast, Jordan.
Yeah, thanks so much. Thanks for having me, guys. We've been a long time trying to line one up, so it's nice to actually eventually get one. I think it was back in 2023 we started talking about lining a podcast, so it's nice to eventually jump on together.
It has been a while, and I'm glad we've finally been able to do it. And obviously Giles is in India. You're off work for a little bit, and you mentioned, and so I thought, hey, let's just try our luck, and it's all working out. Welcome to the podcast, Luke. How you doing?
Good, man. Good to be back for another episode.
How's Alfred?
Alfred's nowhere to be seen, man. He's brushed over, just a bit of rainfall now.
Yeah, okay. Fair enough. So you guys are all safe in Brisbane?
Yeah, man, we're all good. Haven't been affected too much, like a lot of people, losing power and having to migrate to different shelter homes, but that's all right. We're good.
Well, today we're going to be talking about something that is very dear to probably all of our hearts, especially mine. And we're going to be discussing the importance of strength and resistance training on health, overall health, and the physiological benefits of that. There are many. And then we also want to give some takeaways to people that are listening, and then also relate it to clinical practice if we can. Very lucky, obviously, to have Jordan here, who's a fantastic OT. You're a McGill practitioner, correct?
Yes, correct. Yeah, qualified. Yeah.
There you go. So obviously we have a great community. We were talking about it offline before we came online, that there's a really cool community of practitioners, evidence-based practitioners that all talk behind the scenes. Occasionally we get to do podcasts together, or we get to do collaborational posts together, which we want to do more of with you guys. Obviously you guys are doing fantastic work in Perth, and it's always cool to have people just killing it. I always love seeing people that are good at what they do well, especially when they are people that care about their patients and are ethical. There's just so many awesome people around the globe that are doing good work. So when we get to sit down and talk to one of those people, it's always a benefit. And I'm always interested and willing to learn as well. You know, that's one of the greatest things about having friends that are so smart like yourself, is that we can all bring something to the table. You can definitely bring that great bat in the background to the table. It looks fantastic there. Do you want to give us any history on that before we get into the nitty gritty?
Oh yeah, well there's quite a few signatures on that one, and also like to rub into the New Zealanders. We got a Rugby World Cup ball there as well. So we're just talking about before how South Africa's going to do a three-peat and in the next World Cup, but we'll still got a few years, so we'll see how we're going about that. But back to what you're saying, I think it's really to what you guys are doing as a big part of it, and sort of promoting, as you said, this community that we're building. And I think the nice thing about what's the old saying is speak softly but carry a big stick, right? So we might not be the loudest out there, but there's a lot going on behind the scenes, and I think it's about getting a bunch of like-minded people together, and we're all doing it for the benefit of others out there, and so we're lucky enough to have people like yourselves promoting it and being sort of the front runners. So yeah, thanks to you guys for leading the way.
It's our privilege, and we're excited to see where the next few years takes all of us as a community. Like you said, we've got a few people in the community that have really large platforms and large audiences, and then there's other ones that just kind of have their communities and they're doing good work, which is just as important. But I'm excited to see what we can do across the globe when we kind of all come together, and we kind of converge on what is evidence-based and ethical practice. That's when it kind of gets powerful. Okay, so we're going to get into it. We're going to talk about the importance of strength. Clearly, there's a lot that we can get into. I wanted to set the tone, and I wanted to bring a little bit of context before I throw to Jordan. I wanted to set the tone and bring some clarity or some context to what strength is. And the reason why I'm saying this before we get into it is because I feel like many people have an opinion on strength that's very insular, that's very isolated. They think strength is something that it's not. And what we end up getting is people on social media, or even rehab professionals and colleagues and associates and stuff like that, getting the wrong idea when we come along and we say, hey, strength is important, strength is protective of injury, strength decreases all-cause mortality, increases health markers, metabolic markers, increases bone density, reduces we say all these things. Sometimes people can think that we are painting it all with a broad brush and that we don't fully understand the details or the specifics when we do. And so I wanted to start and bring that context, saying strength in itself is not just one thing, right? And this is coined the Williams-Locke strength paradigm. And the way I want to explain it is that strength by itself is not just a muscle contraction or force production. It actually involves four subsystems. Number one, force interactions and force production. Number two, stability. Number three, endurance. And number four, skill. And when I talk about these in terms of the context of the paradigm, the first line of strength would be exerting maximal force via muscle contraction. But then we move on to other important things such as stability, being strength overcoming unpredictable erratic migration of force within, throughout, or upon the body. We call that strength in context of instability. And then endurance is strength over time, and skill is strength, stability, and endurance in harmony. When that system comes together, what most people would think of strength, they'd think of the force production, they'd think of muscle contraction, neuromuscular junction, action potentials, all that stuff. I think we have to keep in mind that and remember that muscle contraction drives force output, and that drives human movement, which is dictated by these force interactions. And it's not just how force is generated and absorbed, but it's also how it's transferred across and migrated across tissues. That's very clinically relevant to rehab. And then strength is also very much about controlling it and not just producing it. And then it's also important to note that with this one subsystem, strength is not always protective, right? So strength in this context alone isn't protective. And that's why when people only think about strength as force production or muscular contraction, they are relatively accurate. What they don't fully understand is the context of the other subsystems. So hopefully that makes sense. The biggest thing I wanted to touch on before I would throw it to Jordan is some of these other subsystems. One of the main ones is stability. We actually talked about doing a podcast on stability, and we'll get around to doing that because I'm sure you've got your own thoughts about that, Jordan, and I'd be really interested to hear. I like to break stability down within the Locke-Williams strength paradigm into a few different perspectives, because this seems to be something that people get hung up on. People really get hung up on the stability component. So let's talk about this. There's the perspective of resisting force. Okay, stability is about controlling movement by resisting external forces. There is the perspective that we are controlling distal deviation over the base of support. So this view focuses on what we would call dynamic stability. This is your ability to keep balance and to control movement relative to your base of support. Okay, essential for cutting, jumping, running, all things that are going to be dynamic. Then we would have the one that a lot of us often talk about, and that would be Panjabi's 3-system model. True stability requires the passive system, the active system, and the neural system to work together in harmony, right? Those three together, integrated together, and having proper contributions from all three is going to create a stable system. And obviously we hear this. Obviously, this is Panjabi's subsystem, but we hear a lot of this from Dr. David Johnson, neurosurgeon, and we also hear a lot of it through Dr. Locke. And I've also heard Jordan talk about it as fundamental to a lot of the McGill stuff. Another way to look at stability can be proximal stiffness. A stable and stiff proximal joint, or core in some contexts, enables efficient distal limb movement and athleticism. What people need to understand is that movement requires foundational stability to leverage upon. Proximal stiffness would equal a more stable foundation, which would equal better power transfer and thus a reduced injury risk. So stability is not just one thing, right? It's task specific. A lifter, a sprinter, a rehab patient all need different stability strategies. You have to train and track it accordingly. When we talk about the next subsystem, we're going to look at endurance. So endurance within the context of this strength paradigm would be endurance is strength over time. So the ability to exert force repeatedly over extended periods. Think about muscle endurance. So the capacity to maintain active contractions is differing from strength due to the mechanisms by which they function. This is the key that we want to zone in and understand here. The reason why endurance is different is because energy systems evolve during endurance. So we're moving from what would be anaerobic systems to aerobic systems, right? And they govern energy availability. And that's why this is a different aspect of strength that we must talk about. Side note, when we had Joel Proskowitz on, we had a really great discussion about strength. And he goes, but Brogan, it's not always about strength, it's about endurance. And I said, you're right. But what is endurance but an expression of strength? And after that discussion, I put pen to paper, and that's when me and Locke created this paradigm, because I got sick, not sick of Joel saying it. Obviously, he's one of the greatest practitioners on earth. But I got sick of other people questioning strength without the context. And that's the interesting about these physical adaptations that happen, and the energy switchover that happens when we're talking about endurance. It's a different subsystem of strength. And as we know, endurance ratios and injury, they have a correlation here, right? So you see where I'm going. Chronic back pain correlates with endurance imbalances between flexors and extensors than strength alone, as McGill has found. And additionally, we also have other work that shows a correlation between not just extensor strength or endurance, but also core endurance and lower back pain. We do definitely see that when we are thinking about rehabilitation or rehabilitative programs, these must be integrated in. The understanding of strength, stability, endurance needs to be balanced with a nuanced approach to address different specific needs and outcomes. And it's not just looking at it through one lens. Additionally, my favorite one out of the subsystems is skill. It can get a little murky when we're trying to define skill, but skill, for the context of this podcast and the subsystem, skill is going to be defined as dexterity or coordination, especially in the execution of learned physical tasks. So if we're going to define dexterity, it's going to refer to the readiness and grace in physical activity, which is essential for smooth and efficient movement. And then we're going to look at, okay, skill requires repetition and neurophysiological adaptation. Like strength, stability, and endurance, skill develops through consistent practice and adaptation. So something you might hear is that we're just going to get someone to move and technique doesn't matter because we can't avoid it. There's no such thing as a objective good technique. This is what some people may say. Now, on the other hand, they'll say it's all about progression and graded exposure. So as long as you do it little and often, you can adapt to anything, right? If you jump off a plane little enough, you can adapt to it. No, it's a joke. That's what Locke would say, right? Obviously, we know we have physiological boundaries and there's some things we can't adapt to, but a lot of these people, that is their line of argument is, okay, as long as it's graded exposure, you can do anything. However, we come into a problem here because what they would say is graded exposure, I would say is developing skill through neurophysiological adaptation, right? So what's the difference between doing something over and over and over again to the point where you get so graceful and so good at that movement? Both those things, I believe, go hand in hand. And so it's a moot point and it's a dichotomy that doesn't need to really exist. Technique matters, so does graded exposure. So the skill is the important part of the system. It harmonizes the system. And what I mean by that is that strength, stability, endurance, and skill must work together to achieve pain-free, functional, and proficient movement. To sum it up, the why requires knowledge, but the how requires graceful competency and ability. It requires skill. Does that make sense?
Yeah, very well said. And again, it's I think where a lot of people's, as you said, dichotomies or controversial debates come about is just misunderstanding of what we're actually talking about. So it's great that you established that context. I think you did it really well, especially with skill being a little bit of a tricky one to define. It's, again, context specific and activity specific, but I think you did a really good job. Then again, it sets the scene in terms of what we're actually talking about.
Yeah, technique's going to always matter, and I think to argue against a statement like that, I know when we discuss, there's people in the industry that are on YouTube saying, lift weight with a loose belly, relax, lift, twist, don't worry about your form, you're causing your own pain because you're guarding. Yeah, we understand if you're over guarding and you're in an acute phase of pain, that compression, that muscular compression on the spine is likely going to be provocative or could be provocative. But to take that and extrapolate that to an entire population or a statement that technique isn't necessarily important, that to me is insane. And it's certainly not something a scientist would do. But I can tell you one thing, if you want to put all the research aside, all of the clinical hours, the clinical experience that all of us have here on this podcast, all of the experience and all of the amazing people around the world that talk about it, if you want to put all that to the side, personally, I've squatted 400 kgs and I can tell you that technique mattered when I did that. So I just want, what I mean? Like if it's going to come down to, at the end of the day, if it's going to come down to personal experience, it's like, okay, it actually does matter from personal experience. Anyway, one last thing I wanted to touch on was, I said when we think of it in an insular way, so we think of it just as muscular force interactions or muscular contractions, which many people do, right? So they're just thinking about strength in one way. When we think of it like that, it's not always necessarily protective, and I think the literature does show that. But when you're looking at it more holistically, there is literature that shows that strength is indeed protective. So when we look at a systematic review and a meta-analysis of randomized control trials, there's one that looks at 25 studies with over 26,000 participants and over 3,000 injuries. So it's quite a significant meta-analysis, and you guys will be aware of it. When they looked at injury risk reduction, they looked at 4 different modalities or intervention types, I should say, which was strength training, proprioceptive training, multi-component programs, and then stretching. And strength training was indeed the most effective with 69% injury risk reduction. Strength training reduced both acute injury, sprains, fractures, overuse, tendinopathy, stress fractures, and that was based on the principle of what we kind of understand to be progressive overload. Down from that, proprioception training was 45%, multi-component programs was 38%, and then stretching was 4%. But I just wanted to finish off that by saying, when you look through the lens and the contextual lens of strength, which is more than just one thing, but that first 4 subsystems, it is indeed quite effective at reducing injury risk. From here, I'll throw over to you, Jordan, and we're going to touch on the impact of strength training on insulin sensitivity. So I'm looking forward to hearing what you have to say about that.
Yeah, brilliant. Well, thanks again for the context there as well. I think it's so important that you underpin that to start off with, because as we were saying, everything's about context, right? And interpretation. So if we just say strength, what does that mean, right? So I think it's a great way to start off there. And you guys would have heard it, and I'm sure a lot of the listeners out there will hear it as well. But it's a common saying that's becoming more and more common for good reason, that if exercise could be put into a pill, it would be the most widely prescribed medication in the world. Right. And it rings true all the time. But as you said, it's about contextualizing that to the specific person, the specific goal, or the specific pathophysiology that you're actually after. And that can quantify it a lot better. And so on that, I want to actually dive a little bit into something that's probably not spoken about as much as I would like it to be spoken about, which is why, I want to dive into it and also so passionate about it. And that's about the impact of strength training on insulin sensitivity. And, for me, the more you learn about insulin, the more I really think it's such a powerful thing that we need to think about in all aspects. And I'm sure you guys have heard about it as well. But now a lot of Alzheimer's are being referred to as type 3 diabetes, right? And so insulin, we used to think about it about just regulating sugar, and that's basically all it does. But there's so much more downstream and upstream that it interferes with in a good or bad way, depending on how you regulate it. So strength training itself has such a massive impact on insulin sensitivity. And I think that should be one of the gold standards or pinnacles that people are trying to work towards in terms of longevity, health span, and just living well, right? It's really one of the biggest markers, at least in my opinion, people should be aware of. So with that, regular strength training has been shown to enhance the sensitivity of insulin, and both in individuals that are healthy, but also in people with type 2 diabetes as well, right? So it's a massive thing. And unfortunately, I think we're starting to see things change in the right direction, but I think there's still an upward trend in terms of the amount of people that have type 2 diabetes or diagnosed with type 2 diabetes and obesity as well. And the improvements that you can see from strength training also facilitate more efficient glucose uptake by tissues, which therefore help to aid in blood glucose regulation. And there's a lot of meta-analyses that have taken place that talk about how strength training leads to significant reductions in HbA1c levels, which is a marker of long-term blood glucose control, particularly in individuals with type 2 diabetes as well. So there's a lot in there, but I want to actually specifically touch on the pathophysiology in an understandable way, but touch on how this actually transfers into what's going on behind the scenes or in the body when we do strength training. Because again, as you're talking about before, Brogan, we can say this big term insulin sensitivity, but what are we actually talking about? Like what actually happens in the body? And I think, as we always like to say in our clinic, the more you can educate, the more you empower people, right? The more we can understand, the better we can actually contextualize things and interpret things to our own individual cases or other individual cases out there as well. So I'm going to touch on just briefly some of the mechanisms that actually take place, and they're all sort of interconnected as well. We're going to talk about them in 4 different parts, but they're all linked to each other, as most things in the body do. So the first one is increased muscle mass and the GLUT4 expression, right? So strength training itself induces muscle hypertrophy, which we all know, which I could do a lot more of. But what we do is we're leading to an increase in the muscle mass, right? And skeletal muscle is the primary site for glucose disposal. So that's where we store a lot of our glucose, and we have it there for a very important reason. So increased muscle mass provides a larger reservoir for glucose uptake. This process is also facilitated by the upregulation of glucose transporter type 4, which is GLUT4 proteins, which translocate to the muscle cell membranes in response to insulin, therefore enhancing the glucose uptake. So what do we basically mean by that? Well, it's about building your reservoir, right? And I always like to say to patients, imagine if you think about a bigger fridge, right? If your fridge is too small, you can't store so much food. And therefore, the extra food that you do have goes bad. And that's basically like the high blood sugar in your bloodstream. So when you build more muscle, it's like upgrading that bigger fridge with more shelves. That's basically what we're doing. So when you eat more and you eat more sugary foods, for example, then instead of it getting wasted and leading to high blood sugar and glucose and all that sort of stuff and insulin resistance, you can actually store it a lot better, more efficiently. And then also the other side of that coin is that you've got more to tap into when you need to, when you're training or running away from a lion or whatever else you're doing. So it's important, and that's one of the first what's actually going on in the body, what I want to touch on. Then the second part is the activation of AMPK, which is the activated protein kinase. And a lot of health podcasts and longevity podcasts talk a lot about AMPK, which is so important. And during strength training, the energy demand of muscle contractions leads to an increased AMP ATP ratio, and that activates AMPK. Now, activated AMPK enhances insulin-independent glucose uptake by promoting GLUT4. So again, we spoke about GLUT4. What it's basically doing is getting more of those GLUT4 proteins to come to the cell membrane, and therefore we can let in more of that glucose. Additionally, AMPK activation stimulates mitochondrial biogenesis, right, which is improving the oxidative capacity and metabolic efficiency of muscle cells. One of the things that were hammered into me when I was at university is that the mitochondria are the powerhouse of the cell. And I'm sure everyone's heard that before, right? Even I actually heard one of our younger patients who came in year 7 was telling me about that. And I was like, oh, that's great. It's coming through. So everyone knows that, right? That the mitochondrial cell is the powerhouse. So what we're doing is basically, if you can think about AMPK like a power switch in your muscle cells, right? So when you work out, when you're training, this switch gets flipped on. And what that does, importantly, is tell your muscles, hey, we need more energy. So your muscles then grab sugar from your bloodstream to fuel themselves. It's just like a car puts in fuel when we're going, and when we want to go further, we need more fuel. So the best part about this is that this process can work even if your body isn't making enough insulin, which is amazing. So that's why it's great for people with insulin resistance. So you can almost think of it almost like bypassing the need per se of insulin when you can tap into this as well. So it's a very, very beneficial one for normal individuals without diabetes or insulin resistance, but in particular for people with insulin resistance as well. Then the next point I want to touch on is the reduction in visceral fat and inflammatory markers. That's what we sort of refer to as, quote unquote, the bad fat, although I think it's got its purpose, but, it's a very broad stroke. Bad fat is visceral fat. But the strength training, what it does is contributes to a decrease in the visceral adipose tissue. And an interesting one, which I can't actually answer too much myself, but I know that they're talking about the actual size of the fat cells being the problem. Probably don't change the amount of fat cells we've got that much through our lifetime once we pass puberty, but it's more about how big those fat cells actually are. So a reduction in the size of the visceral fat cells can actually lead to a lower secretion of the pro-inflammatory cytokines such as tumor necrosis factor alpha, which is a big one, and interleukin-6, which a lot of people have heard about as well. And what those guys do is they actually impair the insulin signaling pathways, right? So they make you more insulin resistant. Explain it to patients as like a factory, right? If we've got a factory that's creating a lot of pollution, if we can decrease the size of those factories, or even in some cases, in some theories, reduce the amount of factories that we got, we're going to put out less pollution, right? And therefore, it's going to be better for the body in a very simplistic way. And strength training does that. It helps to really reduce the size of these factories, if we're carrying on to analogy, and allows the air to be a lot cleaner, and then therefore allows insulin to do its job more efficiently. And that's, again, what we want it to be, is more insulin sensitive. The last one, which is the enhanced muscle capillaries that we've got in the muscles. So regular strength training increases the density of capillaries in the muscle tissues. And this helps to improve the nutrient and hormone delivery, including insulin. And it makes sense, right? If you've got more blood vessels that feed more of the tissue, we're going to have increased nutrient supply and also increased waste product removal as well. So those are the 4 key mechanisms that strength training really does. And like I said, it's not a very quote unquote sexy topic to talk about when it comes to strength training, but insulin for me, it's one of the biggest insulin sensitivity, I should say. It's one of the biggest markers of health and long-term health as well. I know there's a lot of people changing just from lifespan to health span, and I love that. Because, what's the point of living to 110, 120 if you're not really living, right? So I love that we're changing that to health span. And insulin, for me, is one of the biggest markers on that. How insulin sensitive are you? And the greatest thing is that we see from research that improvement starts from anything north than 0, right? Anything north than more than 0, more than doing nothing, we start to see improvements. And there's very few things out there that actually have that effect. So that's my rambling in terms of insulin, and hopefully didn't lose too many people there.
No, it was really, really good. And I've got some follow-up questions as well, because I think what you're saying, especially around health span, it's a bit of a paradigm shift that people need to buy into. And our job as, whether we're primary, allied, healthcare, regardless of what you're doing or where you sit within the healthcare profession, our job is not only to obviously treat our patients, but it's communication and education, right? It's how we educate our patients. And I've heard you speak on this before, Jordan. So what I would like to know is, when it comes to this topic, how do you, number one, how do you screen for it in your clinic? And number two, if you feel the need to discuss it, how do you discuss it with your patients?
Great question. Simply answer the first one. I think it's like you said about education, right? So there's so many people out there that aren't even aware of these sort of things. I think we've done a very mediocre, to put it nicely, job in the past. And, I've heard McGill and I've spoken to McGill about this specific topic as well, but people are not idiots, right? I think sometimes the health profession, whether on purpose or by mistake, almost talks down to patients or clients, whatever you want to call them. And I think we need to actually shift that approach. Right? We're not telling them what to do. We're educating them on what they should know. And again, I could sort of take this in many tangents, but just to go off on a little tangent for a second, like when we see patients, particularly, low backs, that's where I'm sort of doing most of my work these days. And when we see patients and we have the initial consultations and we talk to them, my job is really to educate them as to what is going on and why they should know this stuff. Right. So, you can tell a person, okay, go and do, 5 sets of 8 of this rep and do all that sort of stuff. But unless you actually educate them why they need to be doing it, they're less likely to actually do it. And they're less likely to understand why they need to do it. Right. Just makes sense. So education, as we said, is one of our core values that we have at our clinic, is educate to empower. That's what we're trying to do. And so it's firstly understanding that patients or people in front of you are not idiots. So don't treat them like idiots. Right. If you actually explain to them what's going on, they'll understand it. And so I think that's the first way, is just educating them on it and, give them the resources. And I often tell patients to go and listen to, various podcasts, your guys' podcasts included. This is a great way. If like me, I just plug it on, when we're driving the car on the way to work, or when I'm going for my walks or whatever else I'm doing. Just understanding that education is key. So that's the first part. It's just not treating them like they're idiots. They're actually humans and they can understand stuff if you actually, explain it to them. And we've had our stuff explained to us, through university and otherwise, and from, huge leaders in the space. That's where we learn from, right? So it's not like we came up with the stuff. We learn from other people, and we're doing the exact same thing, just passing it on. So I think that's the first important step, is just to not treat patients like humans, because they'll understand stuff if you explain it to them. So that's how I sort of first broach the discussion around this. And I say, I don't do any, blood tests or anything like that. But luckily enough, we've got a good sort of network around us that I say, okay, go see, these guys, or even just go to your GPs and get a fasting insulin, right, test. And unfortunately, again, like I was saying, sometimes you have the patients really got to advocate for themselves, because they'll often go to and say, oh, I've had blood tests, and they'll bring in their blood test and there's not even a fasting insulin, which for me should be one of the first ones you do there. That we're lucky to have a network around that we can refer to. And that's how I sort of broach the situation with patients, is just explain, there's so much going on in the body, but this is one of the key factors that we should be looking at. And a lot of the patients that I'm speaking to are actually the ones that are quote unquote healthy, right? Like they are coming in with a musculoskeletal injury. And I say, well, we're not just a piece of meat attached to bone. Let's see what else is going on underneath the surface. And prevention is always better than a cure, right? So if we can start it early, then we can get on top of it. And that's how I sort of try and broach it with patients. And I don't make any claims that I'm an expert in the field. That's why we've got great networks around us and great people who are. And that's where I refer on to those people to investigate further.
Yeah, that's a great answer. It's interesting sometimes when you refer out, or when you're working with a patient and you're trying to talk to them about getting other tests, you're absolutely right. Sometimes how you communicate to them and how you educate them does have a big impact on how they can advocate for themselves when they go see other healthcare professionals that may not be as, engaged with their patient. And it's not the first time you'd hear stories about a patient going to see a GP and the GP maybe writing off what the OT said, or what the physio said, or what the chiro said, or what the exercise physiologist said. Like you're saying with the fasted insulin test, often you'll look at somebody's blood test and they'll have like an HbA1c, but they won't have what you're really looking for. And it's interesting that you said that with the fasted insulin, because it's something that you would think would be more widely done, but it's not commonly funded by the government, so it doesn't pop up in what would be a classic blood panel. Overall, the clinical implications of what you're talking about, especially when it comes to strength training and obviously metabolic changes or the influence of insulin, is very interesting. Not only when you talk about group 4 expression, which would be what the increase of muscle mass, but the AMPK activation and the mitochondrial efficiency, the reduction of visceral fat inflammation, another important one, and then enhanced muscle capillarization is another one. So a lot of bang for buck mark when we're talking about this topic, and it's something that people don't often talk about, especially on podcasts. What you said was really good, really clear, and I think there was a lot of nuggets there for people that are listening, especially clinically. And if you're not thinking about this with your patients, if you're not communicating about this or educating about this, it's something you probably should. And so that's definitely, I think, a highlight for someone to remember. So something interesting that I think we should touch on is how strength can be an ultimate predictor of health. This is certainly something that we've heard Peter Attia talk about, and I find it very interesting. So I'll throw to Luke to just discuss that a little bit more.
Yeah, so just carrying on from all those great points from both of you, I think it's a really good topic to talk about grip strength. It's more than just a measure of hand function, essentially. It's a key indicator of overall health, longevity, and quality of life. Consistent research now is showing that lower grip strength is associated with increased risk of cardiovascular disease, all cause of mortality, disability, and even cognitive decline. There was a study that found that essentially an 11-pound decrease in grip strength has been linked to a 17% higher risk of cardiovascular death and a 9% increased risk of stroke. So that's, I think, something really important to consider. Testing grip strength overall can be done with a dynamometer. So clinically, I think that's what a lot of traditional physio clinics tend to use. But just even simple methods in general, looking at things more functional, such as holding a dumbbell or performing dead hangs from a barbell, carrying groceries in from a car. That's all things that we tend to use grip a lot of the time. Stronger grip as well has been linked to better life satisfaction, cognitive function, and reduced symptoms of anxiety and depression. So Peter Attia, as Brogan touched on before, an MD, he actually puts it that not enough can be said about the importance of grip strength as you age. It's one of the strongest physical associations with longer life. So I think that's really important to consider as well, especially coming from a well-recognized name and professional in the medical field. The good news, essentially, when it comes to rehab and strength, which is what we're here for to talk about, is grip strength is trainable. Strength training, especially involving exercises that I mentioned before, gripping, pulling, and carrying, can help maintain and improve this overall, and it makes it a simple yet powerful way to invest in your long-term health, essentially. So as Jordan touched on before, it's not about how far you need to move into things before you get started. It's about getting started straight away. So I think if you look at the professionals around you, look to make sure they've got those on their hands there, got the calluses on, proving that grip strength, and looking at improving overall long-term health function.
Yeah, grip strength is a fantastic proxy for overall health, and hearing Peter Attia talk about it on his podcast, I think is fantastic because he has a wide reach. I think sometimes we can get a little bit lost in the weeds as well. People will come back and argue and be like, well, it's not actually grip strength, like it's a proxy for this or it's a proxy for that. It's like, yeah, we understand, like there's physiological, there's contextually things happening, but it's something that you can do in your practice that's relatively cheap or free. Whether or not you want to use some of those other methods, whether or not you want to talk about it in your history, you want to bring it up in your clinical comprehensive assessment, that's all good stuff if you need to do that. If you want to do if you want to test it a little more efficiently, you can. I know with the police, for example, the men have 120 kg requirement between both hands. I have one at home, dynamometer at home, and I practice. We're looking between young adults to older adults, anywhere between 30 to 45 kg per hand. But it's very easy to have that in the clinic. I don't necessarily measure that metric, but I am very aware of what it means in terms of a proxy for health. And I'm very aware that if there was a problem, like you said, it'll come up in the history. Like you said, Luke, even if they're having issues holding their groceries, like if that comes up in the history, you're going to start thinking, okay, resistance training discussion is going to be coming up next.
Yeah, and it's brilliant, if I may interject there as well. And Luke, love it because, as Brogan said as well, it's a proxy, and I think that's a good thing, right? Like, it's a marker. That's what it is. It's a marker of your general health. It's your marker of how healthy, if you want to put it that way, that you are. And I mean, if we think about it, like, what is a HB1AC test? It's a proxy. It's a marker. And we're talking about the same thing, right? And the great thing about that, and speaking to, again, some health professionals have spoken to Joel, I know you mentioned before, and also McGill as well. And the way I love it is McGill termed it farm strong. Like, you grip somebody who's got farm strength because they're chucking hay bales in the back of their ute, whatever else they're doing. That is proper strength, right? Versus dumbbells and all that sort of stuff, which is great again, and barbells, but that's a nice weighted even. You've got a good grip space. You've got gnarling on the bar, all that sort of stuff as well. But that true farm strength is, a real indication that somebody's, got some good strength as well from there. So I think it's a great point. And as you're saying, I don't necessarily think that the proxy is a bad thing. I actually think it's a good thing, right? Like, it's a marker, and it's one that we should be very thoughtful of, because it's indicated so many different things, as you touched on, Luke, across so many different areas, not just physical strength, but as you mentioned before, things like the cardiovascular health, the stroke risks as well, and all that. So it's a brilliant one, and like you said, it's a very attainable, easy one to actually assess. Number one, a great one for people out there to just keep a track on themselves, but also one that you would see as you start to do other stuff should increase as well. So we get the benefits from that.
It's very relatable too for different individuals on a day-to-day basis, right? You don't have to be training to benefit from grip strength. When you start educating individuals and identifying things where they are using grip on a daily basis, they start to understand it and why it's beneficial a lot more. So we have plenty of markers that we can identify. So it's just about identifying the key ones for the right individual for the right time, essentially.
Yeah, when we relate it back to what you both have just said, for example, when we're looking at the fasted insulin, we're looking at HbA1c, or we're looking at grip strength, a lot of it is a proxy for muscle mass. And we as we understand, when we look at the literature, muscle is a currency. The older you get, it becomes a currency of health and life, not only for metabolic reasons and metabolic outcomes, as you kind of discussed, Jordan, but bone density, muscular strength for movement, as you talked about, Luke, and overall all-cause mortality as well, which we touched on with the grip strength. So these are all, it's funny, we're coming from different angles, talking about different things, but it's all coming under the same umbrella, isn't it?
Yeah, and on that point as well, I think you sort of segued it so nicely there. But the interesting thing is, if you look at a lot of like the literature and studies, particularly done by somebody like Luc van Hoor and others out there, and I know, again, you talked about Peter Attier as well, but the key takeaway for some of the research that's been done, and I like to, given my Dutch background, always promote the Dutch, so a little push there for Luc, but some of the studies that have been done has shown that you can actually take a biopsy of an elderly or untrained person, and they're going to have smaller type 2 fibers, right? Then they've done studies where they've taken them and they've trained them for 3 months and then re-biopsied them, and it shows that the type 2 fibers are now bigger than the type 1 fibers, right? In terms of the amount that they've got as well. So what we're basically saying with that is that then the metabolic response is going to be enhanced. So what I touched on about the insulin sensitivity, insulin resistance. But basically, the key takeaway that I took from that research is that muscle fibers don't seem to get old, right? Like, you can do it at any age. Any age they're responsive, and any age you can grow them. That's what the research has shown. Even I think they did a population, the average mean age was 68. And they showed this, right? So you can, at any age, and they respond normally, quote unquote, like a young person, if you train them correctly and you give them enough, nutrients and stimulus. So you can actually normalize muscle function, not by age, but rather by activity levels, which is massive. So then there's no more excuse of, this is an elderly person. Or, no, we can normalize it by the actual activity levels, because muscle does not age. We don't get old with muscle.
Yeah, and although I know there's a genetic component to what we're dished out in terms of the type of fibers that we have, type 1, type 2, etc. Like you said, you can absolutely impact and grow and dictate how they grow based on the specificity of the training that you do. Those characteristics, those fiber characteristics can change and alter, whether it's kind of endurance training, type 2, or strength power, type 1, or dependent. And the interesting thing about that is that we used to be so connected to reps and sets and areas of intensity, and we used to associate that so heavily with types of outcomes. For example, low reps for strength, high reps for hypertrophy. And there's obviously research in 2017 by some leaders in the field that came out and flipped that on its head, where it showed that, okay, hypertrophy can be achieved through a variety of reps. In fact, when they look at low load training, which was less than 60%, that was 1 to 12 reps. But high load training was actually 15 all the way up to 150. One of the studies in the meta-analysis was 150, but most of them were around 15 to 30. But the key factor, I know there's other studies that show that as long as sets, reps, and volumes are equated for, you can achieve similar hypertrophy results. But this specific study, actually, all sets were the dictating part of it. All sets were performed to momentary muscular failure. So as long as you're training to failure, regardless of reps, hypertrophy outcome is similar. And I know that when this study came out in 2017, it flipped everyone on their head, because this is actually a sub-analysis of a meta-analysis that was done in 2009. And so what that shows you is that like every kind of 10 years, we're getting more and more research. When I started training at 13, we had very limited understanding, and we were very much stuck within that ideology of higher reps for toning, which we know is not a thing. That's fat loss, right? But high reps for toning, medium 12 reps for hypertrophy, 12 to 15 reps, and low reps for strength. But what we do see from the literature, and we did see in this study too, lower reps did in fact increase strength more efficiently, but high reps did still help with strength. So high reps do help with strength, but the lower reps were more efficient, and that does make sense. I mean, especially when it comes to understanding how to train people for powerlifting and strongman and stuff that I've done. I couldn't imagine prepping somebody to lift or compete, or even with what you do, Luke. Like, imagine going to a competition without lifting heavy in the days prior, without doing a peak. Like, obviously, you have to train not only for specificity of training, but for muscular adaptation. So the strength was found to be mostly optimized with the 3 to 5 reps or the low kind of heavier loads. But I think this makes sense. One other thing I would just touch on the back end of this is that exercise selection does impact or influence your rep range, because it comes down to really what you're comfortable with. And what I mean by that is, like, full body compound movements are often going to be more suitable to high loads, especially for ones, like I said before, training for strength-based sports where its specificity has to be a factor. When you've got more joints, compound joints, more muscles taking the load, it's generally going to lend itself to doing more versus, isolated movements, higher reps. And you can sit here and argue about the research and this and that, but a lot of that comes down to comfort. Like, I'm comfortable doing high reps. I'll do low reps as well with a bicep curl, but I'm quite comfortable doing high reps with a bicep curl versus going to failure on squats above 15 reps, 20 reps. I'm not sure if you've tried it, but you're vomiting. You're out back vomiting. So, you know what I mean? So that's kind of, and the fact that it's not necessary to do that when you can, as we know, strength is maximize and primarily optimize through lower reps anyway. So that was just, sorry, I just wanted to touch on that because we kind of went in there with the discussion. And
and again, it's context, as you're saying, right? It's just like we said in the beginning, it's the context. It's what are you after? What are your goals? Like, we talk about it all the time in clinic with patients, and one of the key things I speak to them is like, what are your goals? And I always actually say asterisk, most of the time, pretty much most of the time, although there's some exceptions, people are coming into me because they've got an injury. Like, I sometimes work with athletes and stuff when they're wanting to improve performance, but let's just generalize and say most of the time they're coming into clinic to see me because they've got an injury. What are your goals? And some of them are not to get out of injury, which is can be quite paradoxical to some people out there. But they're like, hey, I've got a meet coming up. I just want to get through that. I'll worry about getting better and healing afterwards. But it's again the context. So my context for that person in terms of the training or rehab is going to be different to the next person who says, hey, I'm really in pain. Let's get me out of pain, and then I can get back to training. So it's, again, as you so nicely put in there, it's the context of it. And what I was sort of alluding to before, and it references straight with your point, is that what's the context of why you're training and what's the goal you're looking for. Right. And that's where you can adjust the reps and sets and all that stuff, as you're saying. But again, the great thing about muscle, and as you said, hypertrophy or strength, is that any age, doesn't matter what age, we can see improvements, which is brilliant. There's not a lot of things out there that actually can across, generations and decades and all that stuff as well. So it's brilliant.
Yeah, we just talked about osteoporosis last episode and discussing how much is too much, when too little is, how little is too little, when trying to figure out the volume, the intensity, the magnitude of load, especially when you've got somebody that would be coming in with a osteoporotic issue, may be likely, or elderly or older, obviously. And so it's figuring out a way to get them into a plan. Like, you need an on-ramp when it comes to rehabilitative programs. And obviously putting an elderly person under a barbell is not going to be appropriate. And so, and actually, I think I remember seeing you did a post on this recently as well, Jordan, and maybe it was like last year or something, but talking about walking, right, and bone density. And that's one of the things where there's research that shows that walking's not enough, but then there's also research that shows that walking is, right? So it's contextual. It's obviously contextual to the person. And then there's research that shows that it's enough to maintain. There's some that shows that it's enough to build, but it's going to be where the person is at. So when the person that's in front of you, because we're treating people, right? Every single person that comes through that door, as we know, they all have their own individual issues. And it's being able to have a comprehensive history, get your head inside of really what's happening, lifestyle factors, etc. And then getting them on, like putting them on an on-ramp that's going to get them into what would be a progressive program. And so I think that's very relevant because when we talk about osteopenia, you're often also talking about sarcopenia, especially with elderly people. And as they start to approach that old, like my mum is starting to approach that maybe mid-60s, and the discussion for me with her every time we talk about health is progressive resistance training. It's high protein. It's trying to make these decisions now because I know that muscle is going to be a very important currency as she heads into her 70s and 80s, and you want to be able to pick up your grandkids and be able to do functional things. So I wanted to touch on some generalized health components as well that are attached to resistance training. Really, this part of the podcast, I'm not going to go too deep into each point, but it's just I want to give the listeners overall breadth of information, right? So it's kind of like standing back and understanding, whoa, I think a lot of people don't realize how much strength can do. And so I want to go through this. It may be a little bit information dense, but I'll just go from A to B just to give you guys an understanding, because so often I know as practitioners, it's difficult to sit down and just sift through information. I've gone and been able to put all this information and collate it all together so I can read it out to you. So I'm going to make this available in the show notes so that it's available to people to click through and have all this research. If you're a practitioner, if you're a clinician, if you're a therapist, I highly recommend that you don't just listen to this episode, but that you do click through the link, read through these articles and go through and digest each article for yourself. I think I don't want to go off topic here, but the ability for you to critically think is so important that I welcome you to take what I'm saying and test it. Don't just take what I'm saying and believe it, without any thought process. We want clinicians and therapists and practitioners out there that are going to have a thought process, that are going to be not only just clinically minded, but also critically think about this type of stuff. So please do the research. Hopefully what we've done today on this podcast has stimulated some thought process for you that's going to help you get better in the context of your clinic or your patients. So strength for health, man, this is a big topic. So let's zip through it. You can lose around 3 to 8% muscle mass per decade after the age of 30, and even more after the age of 60, right? This loss of muscle strength and mass, so strength as well, is associated with disability, increased insulin resistance, decreased bone density, and joint stiffness. So not good stuff. Low muscle strength has been independently associated with an increased risk of all-cause mortality. 2 hours per week of muscle strengthening activity was associated with lowering all causes of mortality, again, independent of aerobic activity. Strength and size in general were both linearly associated with objectively measured physical activity. And quite a large study of 2,292 people, both quad and grip strength, were strongly related to mortality, as we touched on before. Muscle strengthening activities were inversely associated with the risk of all-cause mortality in major non-communicable diseases, including CVD, cancers, diabetes, and lung cancer. Strength training improves, obviously, strength, muscle size, and joint range of motion. That's an obvious one. Resistance training reduces systolic and diastolic blood pressure in some research, which I think is fantastic. It makes sense, right? Strength training reduces lipid and inflammatory profiles, can improve insulin sensitivity and manage blood sugar levels, which Jordan so kindly and brilliantly went over. Men can lose up to 1% of bone mineral density per year, with 1 in 8 experiencing an osteoporosis-related fracture in their lifetime. And so that's very related to training, isn't it? Because we know strength training improves bone density and can help combat osteoporosis. Can improve brain health and enhance cognitive function. May improve cognitive function in relation to academic performance and on-task behaviors in school-age youth. That was a fantastic research that came out recently that we're all aware of. It can improve one's sense of quality of life and reduce depressive symptoms. And a 2019 review of 16 studies showed a significant correlation between strength training and improvements in general health, vitality, mental health, physical function, and pain management. So just kind of blitzing through what would be a lot. We can't go into every individual thing, obviously, because we don't have a 10-hour podcast. But please go on this journey. If you don't already know all this stuff, go on this journey of trying to learn a little bit more about it. And next time you're in clinic, whether it's tomorrow morning or whatever, and you're talking to a patient, start thinking about, if it's appropriate, start thinking about how you may be able to communicate and educate around these things, because likely the way we educate is so much more important than anything we can do that's hands-on.
That's great. I think briefly, regarding education, sort of Jordan touched on it a while back. I think it's really important to not just feel the need to always dumb it down a lot of the time. Jordan touched on, patients are they're not stupid. They are a lot smarter. So I think a lot of the time we see practitioners overutilizing certain analogies that probably aren't entirely correct. So just take the time, an extra 5-10 minutes within your appointment. It'll do a lot of good for yourself and the patient. I know both of you use different models, spine models, shoulder models, knee models to explain different concepts to the patient. A lot of the time, they do respond well to visual learning. I think certain concepts, like a real common one is, how often do you have patients come to you, my back pain is a cause from tight hip flexors. We know a lot of the time that's not entirely correct. So making a little bit more effort to explain to patients different concepts of how muscles work, joints work, how they work synergistically together to operate. And it's an overall concept rather than just pinpointing and isolating one thing, if that makes sense.
Definitely, yeah.
Yeah, brilliant. And as you're saying before, I think it's what you were saying about on-ramping patients in terms of like osteoporosis, osteopenia, that's how I think you get them on board, is education, right? Like, again, it's so key, and it's something that we really strive with and try and get people to do more of, is just education is key. So like we were saying about, the insulin stuff, for example, when I was talking about it, if you can get the people to understand a bit more, then they're more likely to actually take a deeper dive into it for themselves, right? And that's all I'm trying to do, is get people to try and get them to understand things better so they know what they can do moving forward and down the track, right? And I always like to say to my patients a lot of the time is, my job is to get them not to need me. That's what I'm trying to do, right? Like the way that you do that is through education. That's what it comes down to. And again, AMPK, all that sort of stuff as well. Actually say those words. Don't just say, oh, there's a molecular risk, because that will, spark off something. And then next time they see something, well, oh, okay, that's what I heard. Let me just go and, dive into it a little bit deeper. And then they actually become educated. And then, it's a flow on mechanism from there. They can dive into it more, and they start to explain to other people as well. So I think you're so right there, Luke, is getting people to actually take the time to explain. I would say that's 90% of my job, is just explaining what's going on to it. And then, as you were saying, Brogan, and we've been saying the whole time in the podcast, is contextualizing that. That's the real key, I think, of health professionals, is contextualizing it to the person in front of you.
Yeah, big time. And it's also reminding people that strength can be, as we say, when it's in context, is absolutely an intervention, and we shouldn't be only relying on our hands and manual therapy, or even just basic sets of exercise or basic types of exercise, but we should be at some point trying to off-ramp and progress our patients into what would be resistance training. Whether or not you feel comfortable doing that full-blown, or you have another healthcare professional or a strength coach or someone that you can refer to and work closely with. I have people that I know of that are fantastic clinician and practitioners. They're not great at programming or getting their patients into that side of things. So once they kind of work on the acute stuff, they know they want to get their patient into a more progressive strength or resistance plan that is specific to them. They'll refer them on to someone that's more equipped to do that, and that's completely fine as well. Because as we've been reiterating this whole time, it's specific to the patient, and it's about communication and education. We don't want to just kind of be rubbing people down and doing these manual therapy short-term neurophysiological changes, but we want to be having this long-term progressive change and what would be their health span, the journey of their health span. Before I go in and I close on some strength recommendations for people, I am interested to know, if I could, what your resistance training protocol is. So we'll go to Luke second, but I would like to hear from you, Jordan. I actually don't know. I know what Luke does, but I can share mine as well afterwards, and then we'll go through what the research says quickly. In terms of your exercise and resistance-based training programming, what is it that you manage to kind of fit into your lifestyle?
It's a little bit all over the place more recently, and that's because of the little one that we've got on board. It's recently joined us. So, as you would know, Brogan, trying to fit in everything while being a family man and running a business is a little bit tricky. So it's these days it's take what I can get, but there are some fundamentals that I like to keep on top of it. And so for me, and you know, I've been doing it less and less and less because I feel like people get sick of it on our stories. But walking is one of my foundational keys that I always start with. And you know, you'll see it on my stories. I always say spine health walks and all that sort of stuff as well. And because it's such a low bar for entry, right? Like anyone can walk. Well, again, in context, but anybody can do, you know, take those steps to actually improve. There's no cost to go and, you know, join a gym. Doesn't cost you anything. You don't have to drive somewhere or go somewhere, commute somewhere to do it. You can literally do it in your house. You can do it around, you know, your block. And we work a lot with, you know, FIFO workers here in WA because it's a huge community. And some of them, you know, are in the middle of nowhere and it's 48 degrees outside. And I say, okay, just walk up and down your little, you know, 2 by 3 meter room. It'll do benefits for you. So walking is one of my staples, and I try to get 3 a day, short, brisk walks, in terms of, you know, spinal health, but also cardiovascular. And it's also my time to sort of switch off as well. So there's a lot of benefits that I get from that, and that's when I often chuck in a podcast and listen to, you know, a lot of way more clever people than I am. So that's where I try and soak up and absorb it. So that's a fundamental that I try and include is the walking. And 2 to 3 times a day, and then I'll try and get in my strength in terms of, you know, heavier loading. I'm aiming for twice a week, is what I try and get into. You know, at the clinic we've got our gym there, so I either come in before or stay after my shifts, and I'll do some work there. And then I've been trying to do a little bit more recently some, well, if you want to term it, mobility work for hips in particular. I've got granny hips is what I describe them as. They are the most limited range of motion you've ever seen in your life. And I blame my heritage being...
I was going to say that, yeah.
Yeah, absolutely. At least I've got a scapegoat there. But so I've been doing a little bit more work from that. But it's a lot of actually, locks work and the activation protocols that we run through for glutes, which have done huge for me. Because I'm not a fan of stretching, you know, and static stretching and all the rest. And we know that, you know, the research sort of supports that, which is great. But I find it a lot better if I'm actually actively doing stuff as well. So I try and get that in twice a week as well. And then I'll just chuck in a bit more of a hypertrophy whole body once a week as well on top of that, just to try and hit, you know, upper body, back, and then lower body. And it'll be sort of a mix of the rep ranges generally between 8 to 12 as well. Stay with those ones. So getting a, you know, sometimes supersetting and getting the heart rate pumping a little bit, but that's roughly the aim each week. Whether we hit that exactly or not is sometimes a little bit out of my control, but that's the general sort of one I go about.
Yeah, and it's interesting when we talk about stretching real quick, because we know we can increase range of motion through these neurophysiological protocols, agonist, antagonist, neurophysiological, you know, interplay, PAPE, various other things. And most often, actually, it feels a lot better. Accessing range of motion feels a lot better when you're not yanking on cold tissue. Like people go in and they start stretching, and they're like it's the first thing they do, like it's a warm up. I agree. I'm not a huge fan. Again, it's contextual. It's context dependent, and there are times and there are structures that I will stretch, but people need to know out there. And if you don't, you need to pick up a book. But there are mechanisms that can open up joints much better than what just kind of yanking on tissue. Luke, you have recently started competing in weightlifting. You played high-end rugby as a teenager. We see your thirst trap pictures and videos uploaded. So
I'm probably the only fan.
Man, the gym.
Yeah, take us through your program.
First of all, man, I've never been a thirst trap kind of guy. It's
just comes naturally.
Since I've recently moved to Brisbane, the CrossFit gym that I'm training out of it's an old corrugated iron tin shed, man. It gets up to 40 degrees most days. So we don't have aircon. We have those old school fans just sort of blowing everyone's sweat and humidity around the place. So it's not that nice. But yeah, in terms of training at the moment, I'm pretty bad with dipping my toes in a lot of different avenues when it comes to training. So at the moment, I'm in a bit of a 12-week block for weightlifting. So that's, you know, 3 to 4 times a week of pretty much just barbell movement stuff, clean and jerks, snatches, snatch pulls, split jerks, all that kind of good stuff, combined with a little bit of, you know, hypertrophy accessory type warm-up stuff within my plan as well. I find for me, if I don't add in those, unilateral movements or tempo and eccentric loading type movements at the end of my session, can be pretty prone to injury just with based on the type of training weight, like Olympic weightlifting is. It's quite heavy on tendon loading and things like that. I'm also running twice a week currently. So I'm stepping on eggshells with a bit of my training. They don't tend to combat each other too nicely, but I've got a half marathon in May. So there's a big group of us going to Noosa. A few of them are running the full marathon, and I didn't want to be the guy that was sitting on the sidelines, man. So I couldn't fathom just sitting out. So I had to dip my toes in that a little bit. But yeah, overall, it's weightlifting is the priority at the moment. Just going through different strength blocks. The importance for me is making sure I deload pretty regularly as well. I personally believe, if you're not deloading regularly with high level strength training, you're not training hard enough. I'm in deload this week, and I'm definitely in need of it. So yeah, we'll focus on just moving through that week with nice controlled movements and rebuild again next week. So
yeah, it's good. It's interesting to hear. I agree. Obviously, when it comes to deload, often back when I was a strength coach, and that's one of the first things people would look at me strangely about when they would read their program is how much I would deload. I know it's not everyone's style, but I certainly attribute my success to making sure that I deload enough. And I did it quite often because I was training under such high intensities. It's cool to hear that obviously you've got a lot of stuff coming up. You're training really hard. My training's a little bit different these days. For those that don't know, I started training when I was 13. I won a gold medal at IPL Worlds powerlifting super heavyweight in 2017. In 2018, I was the first New Zealander to squat 400 kgs ever in history. And then I did it again in 2019 in another federation to make sure I set all the records so that it was kind of undisputed. And I held that for a few years. And then once I achieved that, I retired. And so retired young, These days, similar to what Jordan was saying, I have 2 kids. So I got one 6, nearly 7-year-old and one 14-month-year-old. And sometimes it can be hard to work around them. But I train 5 days a week in the mornings, and I do resistance training. I start with 20 to 30 minutes on either a Stairmaster or an incline treadmill, and I will do intervals of running and walking. Otherwise, I'll just do incline walking, followed up by basic compound strength movements, push, pull, legs type thing. I train legs twice a week. And then additionally to that, I do 3 kind of 25 minutes rehab sessions where I'm working on kind of all I don't want to say cliche, but the stuff that makes me just feel good, opening up the hips, core stability, shoulder protraction, retraction, stability, stuff like that. And I feel really good. I actually feel the best after I do those. So I've been doing 3 of those. So I kind of hitting all the components of my training. I refuse to, I have a lot of clients that are my age, I'm 34. And after you've been performing at such a high level, it's real common. I have when I deal with sports athletes, it's real common when you kind of come down from that to be like, oh, I'm old, or I'm getting old, or I can't move well. I refuse to believe it will take that. I've got issues from my days training so hard and at such intense levels. When you fly that close to the sun, you're going to have some adverse events. But really, for me, I refuse to be like, oh, I'm old and I'm stiff. It's hard sometimes, but I love it. I get it done. And it's one of my favorite parts of my day. And similar to what you said, Jordan, there's a huge cognitive and emotional element of me kind of having my own time. I think just getting out and doing something's huge for mental health. So to link it all the way back, if you're a clinician and you're not someone that's doing it, and if you've got kids and if it's not your thing, or you've never done it before, or you're busy, we get it. Me and Jordan, we have kids, we get it. We know it can be hard, but we're not all, gonna rip 6-pack and look like the Hulk, like Luke. But if you do have challenges and you're a clinician out there, it's okay just to start small. And something that I like that Giles does, because Giles trains, he does a lot of training, but one thing that he does, I think almost every day, is he walks with a vest on. I know you've done this as well, Luke. You bought it when we were studying. You bought a vest.
In lockdown, man. I didn't have anything, so.
Yeah, so chuck on a vest, and you're going to get an extra 10 to 20 kgs of load, and that's going to.
Everyone's got a local park or a local hill around, so you just go for a couple of walks up there. But like you touched on before, man, even if it is those 20 to 25 mobility sessions that we're doing 2 to 3 times a week. It's not just for your own physical and mental health, but also when you are a clinician, it makes you a better clinician. You're thinking about your own training, but you're also coming up with different ways to apply different exercises, different interventions for different clients. You become more body aware, which is all important, great skills to have.
But yeah, so hey, real interesting to hear from what you guys are saying. I just thought it'd be cool to hear like what we personally do. In terms of actual strength recommendations, if you are interested, I've got some research here. So strength training 2 to 6 times per week. Yeah, there's research showing that you can do like less and you're still going to get a good outcome. And there's also research showing that like too much can have an adverse effect too. So I'm going to say 2 to 6. When you're trying to be broad, you're going to be unspecific, and unspecific is often inaccurate when you're trying to extrapolate it to a person. But what we're giving here, I'm going to give some guidelines just to preface it, right? So strength training 2 to 6 times per week is obviously, we're going to be recommending that bilateral, unilateral, single, multi-joint exercises based on your goals. Beginners, 2 to 3 days, intermediate 2 to 4 days, advanced 4 to 6 days if you can handle it. Again, it's case by case. Reps, sets, intensity, volume can vary depending on goals. This is what we touched on before. The ACSM actually suggests full body workouts for beginners with a focus on 8 to 12 reps, and upper body and lower body splits for intermediates with 1 to 12 reps, be obviously periodizing that, emphasizing on heavy loading as well, 1 to 6 reps. And then reps and sets can be decided by preference as long as the volume is equally equated, similar to what we talked about before. Choosing your rep range and intensity is going to be based on your goals. So often if you're working towards strength, we're going to be focusing between kind of 70 to 100% of max between 1 to 5 reps. Hypertrophy will be 60 to 80% of max, 8 to 12 reps. And endurance will be above with 15 plus reps. But again, that's not always necessarily the case, but it's a good place to go to if you're starting out. And then you want to take notes and focus on progression. That is one of the most important things when we come to strength training is progressive overload. Sets, reps, weight, volume, frequency can all be progressed. Just to finish up is to touch on that study I referenced earlier, that when it comes to hypertrophy, there is research showing that as long as you're reaching muscular failure, you can actually kind of do various reps. So although I gave a few insights and a few suggestions above, it's important to know that one of the most important things that's going to account for your training is how hard you're training.
I think you hit the nail on the head there. And what I'd like to basically just impart is that, like we said before, benefits of exercise training begins with anything above 0. Right. So, sometimes it can feel a bit daunting for people out there, especially if they don't have a background in it or, didn't grow up in sports or much like that. Anything above 0 is going to give you benefit. And that's why, again, one of my staples, in terms of any sort of help is just walking. It's one of the most fundamental things that and as Joel Proskowitz puts it, it's the only actual exercise that we humans were designed to do. Everything else is made up, right? Everything above that is made up. So starting off with very attainable of just walking will do a lot of good. And then obviously as we increase into more resistance training, we're just going to improve the benefits. But yeah, don't be too, daunted by the task of it. Just start with walking, and that threshold for benefit is so low that practically doing anything more than nothing is going to be beneficial.
Real interesting, when you touched on, as long as you're equating intensity, sets, reps, and volume, it's something that I've only recently become familiar with. I remember when I was 15, 16, first in the gym, everything was 3 to 4 sets by 12 reps, not necessarily equating intensity. So yeah, as Jordan touched on, just start somewhere and look to progress and get better.
Absolutely. And we definitely want to reiterate that if you are currently not doing anything, like Jordan said, anything above nothing's going to have benefits. And I think the most important thing that we're trying to convey is just get started. If you're not doing it, get started, because it's really going to have a massive impact on your overall health. And that's what we want to see. We want to see practitioners and clinicians out there that are walking the walk, not just talking the talk, right? But walking the walk. You don't have to go out and lift weights and be a powerlifter or be a weightlifter like me and Luke. That's part of our brand. That's how we promote ourselves. But not everyone has to do that, and not everyone does that. And that's not the measure of your greatness as a clinician. But doing something does bring that connection with your patients, especially when you fully kind of understand what it feels like to get down into a squat, what it feels like to do core work. Sometimes I'm prescribing rehab movements. Like I look at it and I'm like, man, this is a lot. And then I think to myself, I know what this feels like. I know how hard it is to clock these workouts in one day. Putting yourself through the stuff that you're prescribing, I think is important as well.
I was just going to say, I often tell them, man, I'm like, rehab is difficult. Like, you're not a professional athlete that gets to sit out half a season and get paid hundreds of thousands of dollars to just turn up to the facility and, do rehab. Like, you're working a 9 to 5. You're having to fit this in between your day, before your day, at the end. It's difficult. Yeah, it's important for them to understand too.
Yeah, it's worth it. Anything else anyone wants to add?
Oh, all good, man.
Yeah, no, I think we covered it quite nicely there. Obviously, it's a massive topic in of itself, and I think we've dipped our toes in it, which is great. And there's a lot of other areas that we could talk about, and hopefully we'll talk about in the future. But I think that's a great start into it. And yeah, it's been great to discuss it. And like we said, adding the context to it. Yeah, it's been brilliant.
Yeah, and hopefully people have been able to get something from this podcast. The trajectory of our podcast, the Rehab Blueprint, is to provide a blueprint, part of a blueprint every time we start this. So thank you very much for coming on, Jordan. We really appreciate it. Next round, we'll be coming on to yours and we'll attack some other exercise-based health component, I'm sure. Otherwise, be sure to check out this podcast and all the previous episodes, as well as Jordan's podcast, on anywhere you can find good podcasts, Spotify, Apple Podcasts, YouTube, and then we're both often posting to our Instagrams as well. So do you want to shout out your Instagram, your business, and where people can listen to your podcast? I'm assuming it's kind of everywhere.
Yeah, absolutely. So yeah, thanks again for having me on. It's been great, and I look forward to the next round. And we're located here in Perth, obviously, but we do work all over Australia and all over the world with the beauty of the internet, the way it works. And our handles are Perth Injury Pain Clinic across all of our socials, just to keep it nice and easy. We do have our own podcast, the Soft Tissue OT podcast, where we dive into all these sort of topics and similar to stuff that you guys are doing. And feel free to reach out. I'm always sometimes to the antagonization of my partner, but I'm always replying to everyone's questions that they send through on social media and stuff, because I just love it so much, right? I just love talking to people, interacting with people. So feel free to get in contact with us. If you've got any questions about what we spoke about or anything else, I'm always down for a chat.
Yeah, brilliant. It was a great episode, and it was awesome to have you on. I look forward to doing more in the future. Be sure to check the show notes, be sure to click the links, read the research, go check out Jordan's stuff, and stay tuned for the next episode. So thanks heaps for coming on, Jordan.
Yeah, thanks very much, guys. It was really good.
See you later, guys. Each episode, we're going to dive into evidence-based strategies, cutting-edge research, and real-world insights to help you elevate your practice and empower your clients. Okay, so welcome to the Rehab Blueprint Podcast.